Okay, I think this is where we ended our last class on Friday, and I'd like you to listen to this before our class meeting on Wednesday, which will be 11:14. We're going to start talking about the cardiac cycle, and obviously in diastole, this is the relaxation period of the ventricle when it refills with blood. During this diastolic period, this is also when the atria fire. Atrial kick is the term that we use when the atria contract and they squeeze blood through, and we're going to focus on the left side of the heart, is going to squeeze blood through that hopefully wide open mitral valve into the left ventricle, and we're going to get some preload. We're going to get some volume in there before the next contraction. The next contraction is going to be termed systole. So the systolic period is when the ventricle is contracting, generating pressure, and as we know, that's what's going to cause that aortic valve on the left side to open and eject blood out into the aorta. We know that flow occurs because of pressure gradients, and in our case, the pump, the heart, is what's going to generate P1. Downstream pressures are going to be looked at when we look at vascular resistance, but we have to have a pressure gradient. Same thing for the pressure to open a valve. You have to have higher pressure on one side of the valve than the other. We know that these valves are supposed to be and really have to be one-way valves. In other words, when they're open, they fully open. When they close, they fully close. If they don't fully close, a pressure gradient could potentially force blood flow backwards, term that we hear used is retrograde, and blood is essentially getting cycled back and forth between the ventricle and the atria instead of going from the ventricle out to the aorta. So it's like it's stuck in a revolving door. Obviously, we have to have volume in the ventricle in order for it to generate pressure. That's the preload that I talked about. Then we have to have a good strong contraction of the ventricle in order to get an ejection phase. So what we're going to do now is look at the cardiac cycle, and we're going to look at a variety of graphs. The graphs are going to be going from the diastolic period to the systolic period, back to diastole, back to systole. So let's start at the top, and we're going to be looking at the black squares, and they reflect aortic pressure. So the pressure on the other side of the aortic valve from the ventricle. This is the pressure that we're measuring essentially off of a blood pressure cuff. It's downstream from the aorta, but it's this arterial vascular pressure. When we look at the continuous orange line, that's ventricular pressure. And you'll notice that both aortic and ventricular pressures are quite high. They're the highest pressures of any of the measured values. And it makes sense that they would be high, particularly ventricular pressure, because, and we're going to focus on the left ventricle here. Since we're looking at aortic pressures, the left ventricle is driving blood into that aorta. The left ventricle has to generate very high pressures during systole. When we go down a little bit lower, we see the blue circular line, the little dots. That's atrial pressure, and since we're looking at conceptualizing the left ventricular pressures, let's also think about this as left atrial pressure. And it goes up and down through various portions of the cycle, and we'll investigate that as we go along. This lilac or purple, I'm kind of colorblind line, is ventricular volume, and that goes up, goes down to a stable period, which we'll talk about, and then drops during systole when we're ejecting blood. And last but not least, in the lime green, we've got the electrocardiogram. So it's the P, the QRS, and the T wave that we're looking at when we investigate what's going on there. So the first thing that happens electrically is the SA node fires. That electrical activity goes down through the internodal pathways, hits the AV node, goes down through the bundles of His, and then the Purkinje fibers. But when this P wave fires, it causes an atrial contraction. So that generates an increase on this blue dotted line, an increase in atrial pressure. And that increase in atrial pressure is the atrial kick that allows blood to go from the left atrium since we're focusing on the left side, into the left ventricle. So ventricular volume in this purple line is increasing during that period. So once again, that atrial kick helps us preload the ventricle. The next thing that happens electrically is we get the QRS complex. So the Q is the downward wave, the R is the up, down is the QRS. And then we notice that during this initial part of that period, there's no change in ventricular volume. And that's because this portion of the cycle is called the isovolumetric contraction. The ventricle is fired, it's contracting, but there's no blood that's left the system because the aortic valve has not yet opened. Also notice when that pressure increases, we're going to close the AV valve. So the valve in between the atrium and the left ventricle is the mitral or bicuspid valve. And when pressure increases in the ventricle, it should slam that valve shut. So we notice during that contraction phase, ventricular pressure goes up and that AV valve closes. Now, we said there's no change in volume during this period. That purple line is flat because the aortic valve has not opened. So in the green bracket here, we're identifying a significant increase in pressure in the ventricle, but no ejection of blood yet. So we get to the point where the pressure in the ventricle is, the left ventricle specifically we're looking at, is greater than the pressure in the aorta. And that opens that aortic valve. When the aortic valve opens, blood rushes out of the ventricle and into the aorta. So aortic pressure increases as blood goes from the ventricle into the aorta, and ventricular volume decreases as blood goes from the ventricle into the aorta. Now, as systole goes on and blood is being ejected, as the ventricular volume goes down, the pressure in the ventricle is going to go down. You see the drop in the pressure on this orange line. And when the pressure in the left ventricle is less than the pressure in the aorta, it slams that aortic valve shut again. So if it closes, and hopefully it closes completely, blood can't go backwards. Blood can't go from the aorta back into the ventricle. And it should be, actually, the blood should be moving down the arterial tree. So we get a drop in ventricular pressure, and particularly as the ventricle relaxes, we're going to continue to have that drop in pressure. Now, notice that during this systolic period, we go back to the blue circular lines, there's a gradual increase in pressure in that left atrium. And that's because even though this is during the period of systolic ejection, venous return from the lung, bringing blood through pulmonary veins, blood is coming back to the left atrium and refilling the atrium. Because remember, the left atrium is going to fill before it can eject blood down into the left ventricle. So this cycle continues over and over again. So we said the aortic valve is going to close when aortic pressure is higher than the pressure in the left ventricle. And when the pressure in the left ventricle drops to the point where it's less than atrial pressure, the AV valve on the left, which is the mitral or bicuspid valve, reopens, and it allows passive blood flow through the initial part of this diastolic period. So blood will passively go from the left atrium to fill the left ventricle. Then we start another period. I guess I'm rushing ahead of myself. As this period continues, that AV valve is open, left atrial pressure drops because its blood is going from the atrium to the ventricle, and during that period ventricular volume goes back up because we've refilled it. Then we start another P wave, we get an increase in atrial pressure, we get that atrial kick that continues or finishes the active loading part of the diastolic period followed by another systole and another contraction. So this, like I said, the cycle keeps going over and over again, but there are a number of factors that are going to change cardiac output, for instance, when we go from rest to exercise. So the first is this concept of preload. You have to put volume in the ventricle so there's something for it to squeeze. We've got to be able to fill the ventricle with blood or preload it with blood before systole. Afterload is everything that impedes ejection of blood. Anything that's going to resist ejection of blood, that's going to make the left ventricle work harder, is afterload. So preload is pre-filling before systole and contraction. Afterload is during that contractile period, everything that ventricle has to pump against. For instance, we were talking about the aortic valve. If the aortic valve doesn't open completely, if it just opens partially, there's a lot of resistance there. The ventricle has to push against that resistance. That contributes to left ventricular afterload and myocardial work. Contractility, I want you to think of as separate from preload. How much force can this ventricle generate? Now we know, and we'll take a look at in a second, that preload does affect the force that can be generated, or the tension that can be generated. But I want you to think about contractility as just the force that can be generated at a given preload, or separate from the volume that we put in. And if you talk about receptors that we stimulate to increase contractility, those would be inotropic receptors. The fourth factor that we're going to think of influencing cardiac output is obviously rate. And when we think about rate, it's very analogous to respiratory rate. Cardiac output is analogous to minute ventilation in that tidal volume times respiratory rate is minute ventilation. Stroke volume times heart rate is cardiac output. Now my watch, which is a very expensive $25 watch before it went on sale, is actually called a chronometer. So a chronometer measures time. So a chronotropic drug or chronotropic stimulation is going to increase heart rate. So we're going to go back and look at preload again, and there's a very important law called the Frank-Starling law that relates to what we talked about earlier, in that if we pre-stretch a muscle, if you lengthen a muscle before contraction, it can generate more force, or in this graph, more tension. So if I grab my little marker here with my ballpoint, and let's see what color I've got. If we don't have, that'll work, if we don't have very much preload, we're not going to generate much tension when that muscle contracts. If we optimize the amount of preload, I'm trying to draw straight lines, we're going to maximize the tension that can be generated by a given person's ventricle. However, if we overstretch that ventricle and put too much preload in, we're going to wind up having a drop in tension that can be generated. So there's a happy spot, right, where we can generate the most tension. If we have runners in this class that are marathoners, by the time they get towards the end of their 25th mile, they're probably pretty dehydrated. And when they get dehydrated, there's not as much volume in their system to be able to preload ventricles. They're also going to have a drop in tension that the heart can generate, and this may also be one of their limitations to exercise. So I want to make sure that you understand these principles and the cardiac cycle before we get to class on Wednesday, because we're going to start talking about more of the things that we're going to have to quantify in the circulatory system.